Je ne crois pas que mon image apparaît. Est-ce qu'on a un bug?
Non, c'est beau.
C'est beau. Alors, bonjour tout le monde. Good afternoon. Alors, j'aimerais débuter tout d'abord en vous remerciant pour vos efforts quotidiens, pour nos patients, pour leurs familles, puis aussi pour la population en général. On va en parler un petit peu tantôt de la vaccination, parce qu'on reçoit des gens qui viennent se faire vacciner chez nous, qui ne sont pas nécessairement nos patients, mais qui sont très, très contents de venir au CUSM. Alors, I hope that you had a very nice and beautiful Easter or Passover or whatever. The weather was beautiful. The hospital was not so busy last weekend, so I know that some of you were able to take a few days off that were well-deserved. Il y a aussi le mois du Ramadan qui s'en vient bientôt pour nos collègues de religion musulmane. Et pour ceux d'entre nous qui sont un peu moins de religieux, je pense qu'on peut simplement célébrer puis profiter de ce printemps qui est magnifique jusqu'à maintenant et dont on avait bien besoin. Le programme du jour, je vais donner quelques informations sur la campagne de vaccination, aussi bien pour nos employés que pour la population générale. Then, Dr. Marie-Astrid Lefray, who's the Medical Director of Infection Prevention and Control at the Children's, will put us up to date on the COVID situation. Par la suite, j'ai le plaisir de vous représenter, parce qu'elle est déjà venue vous parler, le docteur Gail Mir, une collègue de ma classe, médecin psychiatre, qui est directrice du module de thérapie cognitive behaviorale, ici au CUSM, qui va vous parler de l'importance du bien-être psychologique de nos travailleurs en temps de pandémie. Puis par la suite, Mme Alfonso va animer, comme elle le fait si bien, la période de questions et de réponses. Et on sait qu'il y a beaucoup de questions et on va essayer d'y répondre le plus possible. So, the next slide, please. Alors, where are we now with the employees, doctors, residents, students at the MUHC? Well, we're up to 10,721 people that have received their first dose. Alors ça représente à peu près 80% des gens qui travaillent ici ou qui étudient ici. Il y a 10 jours, il y a eu un tableau qui a été présenté par le ministère de la Santé sur le degré d'avancement de la vaccination chez les travailleurs de la santé. Et à part les dispensaires nordiques, le CUSM est l'établissement qui a le plus haut pourcentage de travailleurs vaccinés au Québec présentement. So I'd like to thank everyone who's been involved in vaccinating our staff. I'd like to thank our employees for accepting to get the vaccine. I think it's very, very important, and we're doing quite well. So thank you very much. Et ça, c'est en date d'hier, et on continue à vacciner. Alors, la prochaine diapo, nous allons maintenant regarder la population en général. So up to now, over 29,000 people have shown up either at the Glen site in the RI atrium or at the MGH, Livingston Hall, to get their vaccines. We've been administering up to today only Pfizer vaccines, but today we're part of this effort to vaccinate with AstraZeneca without appointment. It started this morning at 8 o'clock at the Montreal General, and I'm told it's going quite well. We should be reaching our target for the day, which was 600 people without an appointment. On vérifie aussi là-bas au général si c'est pratique de continuer sans rendez-vous. Parce qu'on veut voir comment les clientèles vont se croiser. Au général, il n'y a pas énormément de place, surtout dans le coin du Livingston. On sait qu'on a la clientèle d'hémodialyse aussi là-bas. Donc, en même temps, c'est un test aujourd'hui. Peut-être qu'on en viendra avec rendez-vous pour l'AstraZeneca aussi. Alors, j'irai à la prochaine diapo. Oui, absolument. Alors, écoutez, les directives sur la priorisation des travailleurs de la santé, I'm sorry to say that it changes. I wouldn't say daily, but it's almost daily. Just before this webinar, we got another email from the ministry with more precisions on who should get the vaccine and who should be waiting a little bit more before getting the vaccine. So, of course, as you know, we do have a committee which is chaired by Dr. Eva Sidorovitz, our medical director. to take a look at all these guidelines and decide who's getting the vaccine within our healthcare workers, also within our partners who work in the hospital but are not our employees, for example, people who work in the concessions, etc., etc. So, alors, depuis le dernier webinaire, il y a un nouveau groupe qui est le personnel en contact direct avec le personnel donnant des soins et des services. Donc, ça, c'est nouveau. Avant, c'était le personnel donnant des soins et des services. Of course, those people from the first wave who didn't want to get the vaccine, they were offered the vaccine, they refused the vaccine, they can come up at any time, raise their hand and say, yeah, I've changed my mind. I'd like to be vaccinated. And you're always a priority for us. So you'll get the vaccine. La deuxième dose, on me questionne souvent sur la deuxième dose. On est toujours là, la même chose, 16 semaines, 16 weeks, which is about 16 weeks, 112 days. So it might vary a bit, let's say between 100 and 120 days. We're expecting a lot of vaccines at the end of April and May and June. So that shouldn't be a problem. On devrait recevoir la deuxième dose du même vaccin que nous avons reçu lors de la première dose. So most of you either got at first Moderna, I think, people who work in la Chine, les gens du CHSLD à la Chine, je pense qu'ils ont été vaccinés avec du Moderna, pas mal au début. Donc, vous devriez recevoir du Moderna. C'est nous qui allons vous le donner. Et the other workers, those who work in the hospital, you mostly got Pfizer, I would think, most of you, if not all of you. Alors, ce sera aussi du Pfizer. L'AstraZeneca, pour l'instant, est réservé aux personnes de 55 ans et plus sur une base volontaire. Alors, vous pouvez parler à votre gestionnaire, talk to your manager to get an appointment, to get vaccinated if you think you're part of these groups. Prochaine diapo. Alors, j'en ai parlé un petit peu. So, AstraZeneca, sans rendez-vous, without an appointment, 55 years old and over, starting this morning. If you're a staff member over 55 and you haven't been vaccinated yet, you're not part of a priority group, you can show up to these clinics. And we will make sure that that gets into your health record et au bureau de santé. Alors, et puis pour nos travailleurs de la santé essentielle, du réseau de la santé, puis des réseaux connexes aussi, les pompiers, les policiers et tout ça, il y aura des vaccinations sur rendez-vous dans une clinique de vaccination. So, who's next as a priority? Les personnes avec une maladie chronique. So, we just got the list about an hour ago. Essentially, people that have a chronic condition that requires a regular hospital follow-up will be vaccinated in the hospital, in the clinic. So we just found out about the different groups. So stay tuned for more precisions on that. And we'll start vaccinating these people probably on Monday in the outpatient clinic. And also people who are in the hospital with a chronic condition, they will be vaccinated before they're discharged. So that would be starting on Monday. Voilà. Alors, ça fait le tour, je pense, de la vaccination. Et je vais laisser la parole au docteur Lefebvre qui va nous faire la mise à jour usuelle sur l'épidémiologie de la COVID-19, de cette troisième vague. Docteur Lefebvre, la parole est à vous.
Oui, merci, Dr. Feller. Bonjour tout le monde. Hi, everybody. So I'll give you today the update on what's going on with COVID-19 in the province. So as you're probably all aware by now, we are in the third wave. Unfortunately, as much as we wanted to not be in it, it is a reality. So the cases are increasing. So this was the number from yesterday, and we're at about 1,600 cases today. So representing a significant increase compared to last week. And it's particularly concerning in a couple of regions, most notably Quebec City, Chaudière-Appalaches, Outaouais, Laval, more so than the island of Montreal. About a quarter or a little less of cases are on the island of Montreal lately. Prochaine diapo. Donc, le fameux taux de reproduction dont on vous parle pas mal à chaque webinaire, donc le nombre de cas générés par un seul cas est en montée continue depuis les dernières semaines. Donc là, on est autour de 1,2. Donc, ça veut vraiment dire que l'épidémie en ce moment n'est pas sous contrôle. À Montréal, par contre, le taux de reproduction se situe autour de 1. Donc, on est un petit peu optimiste qu'à Montréal, les choses, du moins pour le moment, sont relativement stables. Next slide. In terms of the positivity rate, so out of everybody who gets tested, the percent that are positive. So in the entire province, we're looking at around 4%. Montreal and Laval together about 5%. But if you look at Outaouais, it's upwards of 8%, and Quebec City around 5%, and probably getting higher now as we speak. Prochaine diapo. En termes de la distribution des cas par groupe d'âge, donc on voit encore ce qu'on remarque depuis la deuxième vague, puis encore plus marqué là, ces temps-ci, la prépondérance de cas chez les jeunes personnes. Donc chez les enfants dans le milieu scolaire, c'est évident, mais dans le groupe d'âge de leurs parents, donc 20 à 29 ans, 30 à 39 ans, 40 à 49 ans, vous pouvez voir ici, c'est vraiment eux qui représentent la majorité des cas dans la communauté en ce moment. Comme vous voyez, dans les groupes d'âge plus élevés, en haut de 60 ans, on retrouve une proportion de cas nettement inférieure. Next slide. Prochaine diapo. Donc, les hospitalisations, ça nous inquiète. On commence à voir une hausse des hospitalisations qui est assez évidente dans les derniers jours. This graph is showing you basically projections that are actually made at McGill in collaboration with INES. In terms of the hospitalization. So the black curve is the curve in the worst case scenario if the epidemic is really out of control and there's a continued increase in hospitalizations. This is what would happen. As you're seeing with our current hospitalizations, we're going a little bit above that worst case scenario curve right now. So that's quite concerning. This is no longer the trend that we were expecting. This is not fitting the trend that we were expecting a couple weeks ago. So we have to watch this closely. There's yesterday there were, or that was the day before, 533 admitted patients, of which about a quarter in ICU. It's probably changed by now. Majority of hospitalizations were still in the greater Montreal area, though with what we're seeing in Quebec City and Chaudière-Appalaches, I believe that this will shift soon. Prochaine diapo. In terms of outbreaks, so the good news for us in healthcare is that we continue to be the minority of the outbreaks. Et comme vous voyez sur la diapo ici dans le tableau, c'est vraiment encore les écoles et les milieux de travail qui représentent la grande majorité des éclosions dans la communauté. Donc, on voit ici l'effet de la vaccination dans les milieux de soins où vraiment il y a beaucoup moins d'éclosions que ce qu'on voyait à l'automne et même début janvier pendant la deuxième vague. Prochaine diapo. Variants. So variants are becoming the predominant strains. It's no surprise. They spread very well, and they're basically replacing the original strain. So this is data from the Institut National de Santé Publique du Québec. About 66 or 2/3 of cases in the province currently are variants. In Montreal, we're looking at about 45% of cases that are variants. And you see the graph down here that is showing you the projection that basically by mid-May, 100% of the circulating cases will be variants. Prochaine diapo. Hospitalizations at the MUHC are starting, unfortunately, to mirror a little bit what's going on throughout the province. So we're starting to see a little bit of an uprise in our hospitalizations. So we have to keep a close eye on that. And the surge committees are working hard at ensuring that we have the bed capacity to care for our COVID patients. Prochaine diapo. En termes des taux de positivité au CUSM, ça demeure quand même relativement faible. Donc, quand on regarde le tableau en haut, c'est nos patients qui se présentent aux urgences avec des symptômes ou bien nos patients hospitalisés avec des symptômes. On a un taux de positivité d'environ 2%. Donc, de tous les tests qu'on fait chez ces patients-là, 2% vont être positifs. Et quand on regarde le tableau en bas, nos patients préopératoires ou pré-procédure, qui sont en général sans symptômes, qui n'ont pas eu de contact, qui sont peut-être isolés un peu plus dans les 2 semaines précédant leur chirurgie, on a un taux de positivité à seulement 0,5%, donc très, très faible. Donc, encore une fois, très encourageant et rassurant pour nos équipes chirurgicales et anesthésistes qui s'occupent de ces patients-là. Next slide. Cases in our healthcare workers. So this is, again, like the rainbow is really shining there. Given the vaccine, we're seeing much less positive healthcare workers still. So this trend that we've been seeing since end of February and March has maintained itself. We have less than 10 cases per week, sometimes 5 or less. So we're really, really, really happy to see that. And really, we don't have another explanation except the vaccine. So, prochaine diapo. And another direct effect of the vaccine is we can say we have no outbreaks at the MUHC of COVID-19. Ça faisait très longtemps que ce tableau-là qu'on distribue à chaque semaine n'avait pas cette allure-là. Donc, on est extrêmement, extrêmement content de voir qu'on n'a pas de transmission au sein de nos murs. Et vraiment, c'est l'effet du fait que les gens sont protégés. Next slide. So vaccination in Quebec, Dr. Feller already alluded to some of this information. So we're now at about close to 20% of the population having gotten their first dose. In terms of the protection by age group, so in the 80-year-old plus, we're at close to 85% who have gotten their first dose, 70 to 79, 75%, 60 to 69, 33%, and these numbers might be higher now as we speak. And Dr. Feller already mentioned the new groups that will be vaccinated shortly. Prochaine diapo. Donc, un petit peu d'espoir. J'aimerais vous parler de l'histoire de succès qui se déroule à l'autre bout du monde et qui démontre vraiment comment la vaccination peut tout changer dans cette pandémie. Alors, it's the Israel success story. So, as you probably heard, because it's been in the media a lot, they have rolled out their vaccination, early on in mid-December and quite quickly with the 2 doses, and they've now vaccinated so 56% of their entire population with 2 doses. However, if you think about it, the denominator here includes children, which are not yet part of the vaccinated individuals. So if you take the age group of 50 and above in Israel, greater than 85% of them have been fully vaccinated. Prochaine diapo. So this is their daily number of new cases. So the arrow that you see there points to the onset of vaccination campaign, which was mid-December. So they did have their second wave, as most countries have had around the world. But then you really see a nice trend down that is really a direct effect of vaccination. They did have some lockdowns in January, but I have to say in recent weeks, since mid-February, they've progressively opened their society and now are pretty much fully open with very little restrictions in place. But they do have the vaccine passport being implemented in several public places throughout the country. But despite wide opening, we're not seeing a surge in cases there. Prochaine diapo. Leurs hospitalisations suivent le même chemin. Donc, on voit que les hospitalisations chez les individus en haut de 60 ans ont diminué progressivement depuis le pic de la deuxième vague, et de même que celles des 0 à 59 ans qui, eux, ont été vaccinés plus tardivement. Donc, vous voyez que leur hospitalisation montait dans la deuxième vague, mais là, on commence à voir, on voit vraiment une tendance à la baisse qui est similaire à celle des personnes plus âgées. Next slide. And same thing with their deaths. So the deaths were high at the peak of second wave, but now they're seeing less than 10 a day, and then there has to be a direct effect from vaccination there. So this is the infection control prescription for the coming weeks. If you haven't gotten it yet, get it. Comme Dr. Feller l'a dit, ceux qui n'ont pas encore eu leur première dose parce que vous hésitiez, le vaccin est là, on va vous le donner. S'il vous plaît, considérez-le fortement parce que c'est vraiment la seule chose qui nous sort de cette pandémie dont on est vraiment, vraiment tanné après 1 an ou plus. Prochaine diapo. So a little bit of humor to leave you. Merci.
Okay, so I assume I'm speaking now, or?
You are, Gabe.
Okay, thanks very much, and thank you for having me today. So today I'd like to just touch base with you about maintaining our wellness during this third wave. And I'm calling this kind of post-traumatic growth, the difference between surviving versus thriving, riding the third wave. When I last spoke, let me just get this happening here. I will speak to you about some resources for mental health just towards the end of this talk. But when I last spoke to you, it was in November during the second wave. So now here, we're in the third wave. What's different now? You know, the positives are we have high vaccination rates, as Dr. Lefebvre just explained to us, the effect that the vaccinations had both on us locally and internationally. So we have a greater sense of personal safety. We're accepting of the new normal, safety protocols, PPE. We have now kind of gotten used to, after over a year of this, we have established routines at home and at work. So more of a sense of control. However, for most of us, it's been a long time since that kind of a real holiday from stress and work, that the exhaustion is accumulating. For many of us, there's an ongoing exposure to these COVID deaths and others. And now as we're getting more tired, there's a third wave coming, which is the idea of maybe we're going to have a strain on our resources, and we have like more to do with less, and we have less gas in the tank. And so it's a little bit like I talked about the marathon mentality in November, but what we're dealing with now is like, it's almost, we're running the marathon and we're just like almost at the finish line. And then someone said, okay, just another 10 miles. Like, it's going to end. It's a hard time at the very end of what seems like the end of a race to keep going. So how are we going to do that? Now we know, and many of you have experienced some of these things in this last year, the occupational hazards of compassion fatigue, of vicarious traumatization, where we've seen families and patients being traumatized or our colleagues traumatized, how that affects us. The idea of moral injury, when we see things that just don't seem right, that we see things happening that we don't feel comfortable with. The idea of burnout, we'll come back to that in a minute. And those of us that have had already tendency towards anxiety or depression find these things may have exacerbated in the last year. And some folks are, for the first time, experiencing some mental health disorders. Now, as far as burnout is concerned, I want to remind you that there's sort of a tryout that's involved with burnout. Waking up in the morning feeling exhausted, dismayed at the idea of having to face another day on the job, feeling at the end of the day entirely used up. Then there's this idea also, especially for those who do direct patient contact, of feeling depersonalized, being more callous towards people, not caring as much as you used to care. And another one, which is striking that we see in people, is this sense of reduced personal accomplishment. Even people who are working like dogs and contributing enormously are suddenly feeling like what they're doing doesn't make a difference. They have no influence, they haven't accomplished worthwhile things. Now, if you see this starting to come up, the beginning of burnout, it's the best place to try to head that off at the pass and seek help. This differs, of course, from, for example, clinical depression, where people feel exhausted, demotivated, lack of interest for their usual activities 7 days a week, whether they're on vacation, whether they're at work. Burnout's largely related to how you feel Sunday night having to go in on Monday. Friday, Saturday, if you have a weekend off, doesn't feel the same. So this is burnout. So how do we manage these hazards? Now, the literature indicates that organizational level and team level interventions are the most important to maintain, worker health. So what I wanted to focus on today is what you can do individually. What do we do at the individual level? Which is really a story about coping, right? And there's three kinds of coping that I guess you're all starting to be aware of. There's the problem-focused coping, emotion-focused coping, and meaning-focused coping. Now, problem focus is the easiest one. We get that. We have a problem, we confront it, we face it, we generate as many solutions as possible, we choose a solution, we act on it, and it involves instrumental actions. Emotion-focused coping has been stressed since the beginning of the pandemic. And that's when we're talking about like so-called stress management to allow us to handle the stress and distress that may come from our work. So advice that you're constantly given are, to plan your breaks at work. Think in advance how you're going to spend it. Give yourself a few moments of relaxation or mindfulness. Now, out of work, make sure that you rest. Don't check up on how your patients are doing. Exercise. You might have spiritual activities that you do. Relational activities with people in your life. And the idea of being mindful of your own mental state. So if you notice that you're feeling dysphoric, overwhelmed, you don't care, you're angry, you feel guilty, use these feelings as a sign that you need some help. Even if it's talking to a colleague, consulting a peer. There's some peer support groups that have been organized where you can discuss these things to reach out for help. If you notice, for example, you're overcommitting to work, excessive self-sacrifice, that also may be a sign that you're not paying attention to your own emotional life, and to watch for that. If you have unwanted memories, if you've, for example, been working frontline and you have seen awful things, don't suppress them, accept them. And if you find you're ruminating, overthinking, you should have done this, or what's going to happen next, this is not productive, so you try to help yourself disengage from that. So this is emotion-focused coping. But what do you do now? Now, by the pandemic, we've all kind of figured out, or we're working on emotion-focused coping. It's pretty hard to do rest and balance and everything when you're doing a double shift and people are off work and you're trying to organize stuff, and it's only going to get worse. So emotion-focused coping has its limits, as we've all found. You can solve problems, you can deal with your emotions, but it's going on. How do we endure? And that brings us then to the third point, which I think is a good point for us to remember in the third wave. And that is the meaning-focused coping. Research has shown that folks that can reappraise their stressful events in a positive way, people that can see silver linings, manage to maintain their motivation and sustain their coping and well-being in a difficult time. So what would that mean? That means actually drawing on your own personal beliefs, your own values, your own goals in life, and tying those into what you're doing. So for example, when I'm meeting people now and they're dealing with really tough situations, they're often telling me how they can endure, how they do it. Some people say, well, it's because it's the right thing to do. Or they might have a spiritual aspect of it. It's what God would want you to do. Or they're thinking like, in 5 years' time, how would I like to look back on this period? What would I like to have said about myself? How I got through this particularly tough period where everything seemed just so hard. This benefit finding, this positive reappraisal, reflection about meaning has been shown to result in less depression in workers under stress and greater personal growth after disasters. Now, the APA, the American Psychological Association, in 2016, published these 10 ways to build psychological resilience. And you'll see in a lot of these meaning-focused coping suggestions here. So they're talking about connections with family and friends, the importance of that. They talk about the approach to crisis as avoiding seeing them as insurmountable problems. They talk about acceptance of change, seeing that as a part of living and circumstances that you cannot alter. They talk about moving towards your goals, but also making them realistic. And in the face of adversity, to take decisive actions, act on adverse situations rather than being passive. Look for opportunities to discover more about yourself and gain an increased sense of self-worth, to nurture a confident, positive view of yourself, keep events in perspective and not blow them out of proportion, which is a tough one. Keep it in perspective. Maintain a hopeful outlook, visualize what you want, and finally, take care of yourself by paying attention to your emotional and physical needs. So they talk about resilience here as being a process, not a trait, not a resilient person by nature, but by doing these things, you're developing your resilience. And the last concept, though, I'd like to bring to your attention here is the difference here really between resilience and actually post-traumatic growth. And I always think of resilience like the ability to bounce back from a stress, those, when you're a kid, you have those little things that you bounce and they come back up, when kids are punching them, they come back, they survive all the things that have come their way. But there is also literature now on post-traumatic growth. In other words, you don't bounce back as good as you were before, or as less damaged, or with less deficits. You're talking about thriving, growing, in fact, bouncing forward. So we're talking about post-traumatic growth, which transcends the mere fact of overcoming stress, transcending coping with it, adjusting to negative impact. We're talking more about the process by which individuals accept and transcend a traumatic situation, to derive meaning from it, to gain wisdom, and strengthen their own personal resources. And research has shown again that people that can see opportunities for growth at the end of a period of trauma experience a positive sense of self, find themselves feeling more competent, more assertive, and in fact better able to manage future stresses. Relationships can improve as well, as people who have been in a vulnerable situation or felt vulnerable may become more comfortable with self-disclosure, whether it's to colleagues or family. And in this process of relating differently to other people who are actually all co-sufferers in this situation, will lead to increased sensitivity to others in the future. And of course, the pandemic has affected all of our lives and really has us all kind of thinking about what life is, the meaning of life. It may challenge some beliefs we have, whether religious or otherwise. And our philosophy of life then often will also reflect this post-traumatic growth. So to summarize, COVID-19 has profoundly altered every aspect of our lives. Emotion-focused coping can reduce distress through specific strategies at home and at work. Meaning-focused coping draws on our personal values to sustain motivation and coping during prolonged difficulties as we're in now. Post-traumatic growth can and will occur, resulting in stronger personal resources and better preparation for future uncertainty. And I'd like to just finish with a quote from Helen Keller, who was a famous American author who at 19 months of age developed, I think, rubella or viral illness and became deaf and blind, but went on to become a very influential American writer and disability activist. And she wrote here, although the world is full of suffering, it is also full of the overcoming of it. That's what I like to say today. I would like to just finish, and you'll have these slides uploaded in terms of resources if you yourself feel that you need something that your current situation is not getting. For example, if you're going to download some apps to help you out, I would, number one in my book is COVID Coach, which is an excellent app. It's got like quotes every day. It's got how to manage stress, things to learn about mood checks, resources. It's an excellent professional app. If you're having trouble to sleep, my second favorite app is CBTI Coach, put out by the same people. These coach apps are great, and they help you figure out learning about sleep, stress, quieting your mind, managing stress. There's self-directed websites. CAMH is a great website, WHO, they're improving mental health during a pandemic. And finally, if you feel the need for more resources for physicians, there's PAMQ, the Programme d'aide aux médecins du Québec. For non-physician employees, we have the Programme d'aide aux employés. And we have our in-house from the Mental Health Mission. We have the MUHC CARES program, which is open to any MUHC staff who feel they need a rapid response. We do a rapid kind of evaluation and see what's needed. Dr. Jen Russell, the interim head of psychology department, and myself will quickly field these calls, triage them, and see what we can do to help you out. So on that note, I guess I will move on to the next thing on the agenda. I think it's questions.
Thank you very much, Dr. Myers. It sure resonates in this person, and I'm sure in many others. Thank you also to Dr. Lefebvre. Dr. Lefebvre was not available today to do this presentation, rearrange her schedule. Alors, merci beaucoup, Dr. Lefebvre, d'avoir été là aujourd'hui. Votre présentation a provoqué plusieurs questions. Il y a aussi un nombre impressionnant de questions sur la vaccination. Alors, on voit que Patricia Lefebvre, Eva Sedorovic et Dr Lefebvre pourront aussi répondre. Quelques questions sur les masques. Caroline Dubé est avec nous. Alors, Rachel, on vous écoute pour la première question.
Yes, the first question we have is about the second dose, because quite a few employees are approaching their 4-month date, and they're wondering if how they're going to get learn about getting their second dose, and also whether it will be the same as their first.
Thank you, Rachel. Patricia?
Yes, hi. So good afternoon, everyone. So the second doses are going to be the same vaccine as you had the first time. So for most of our MUHC healthcare workers, it's going to be the Pfizer vaccine, so the one that you received. We have a few exceptions with the Moderna at Camille Lefebvre. The second dose has been planned. So we'll start to vaccinate April 12th, so next week. Your managers will be receiving the same way we proceeded the first time. So all the managers, if it's for a physician, it goes to the DPS office. If it's for residents and trainees, it goes to Hélène Khalil. And everyone will receive the allocated slots. They're going to be receiving your names because we have everyone who was vaccinated and the date of vaccination. And based on your schedule, they will book your appointment. And you will receive confirmation and email from the HR group as soon as you are being scheduled. The first 2 weeks, as we remember, these were the ones vaccinated between Christmas and New Year's in the first week of January. So even if you were vaccinated off-site, so you were vaccinated at Centre Ouest or Ouest de Lille, we'll be offering you to be vaccinated on-site. So it's going to be a few hundred. But as soon as we start the week of April 26th to the week of May 24th, we'll be doing almost everyone, everyone that was actually vaccinated in the first cycle. So within the upcoming month, everyone will be receiving their second dose. And it's going to be either 112 days or before, the week before. So this is if people are available. We know some people may not be available. We'll make sure, as we do for the first dose, we'll every time resend the list to make sure people get vaccinated.
Merci, Patricia. Rachel, question.
There's a follow-up question about whether or not there's any chance that the 4-month delay is going to be reduced. Can we?
At this time, the allocation of the vaccines is based on that 4-month delay. So we receive vaccine on a weekly basis based on people who were vaccinated 4 months ago.
Maybe to clarify, Rachel, this is not the MUHC who decided on this delay. It's the ministry with the allocation of vaccines.
Yes, okay. There's many questions about eligibility because of all the news that's come out in the last day. For instance, essential workers, are administrative people considered essential? Are all MUHC RI people considered essential?
No, so administrative personnel are considered a general population. So they're not travailleurs essentiels. So the travailleurs essentiels sont daycare center, les centres de petite enfance, primary school, high school. We have the firemen and the police officers. These are the essential, and we don't have those within our group, but yeah, there's also the staff in the centre de détention. So these are the ones that are considered travailleurs essentiels.
Yes, and we have other eligibility questions. Je suis employé secteur administration avec maladie chronique, moins de 55 ans. Est-ce que je pourrais me faire vacciner à l'hôpital du CUSM?
Dr. Sidorovic?
Yeah, so good afternoon to everybody, and also want to thank the two presentations by Gail and Marie-Astrid. They were wonderful. So I just want to make a few comments on the answers that have gone forward. First of all, for the physicians, please do not start emailing myself or Najwa. We know who you are, and we will be giving the appointments. So we're keeping an eye on things, and if in a couple of weeks you haven't heard, then maybe. But I just don't want to encourage an avalanche of emails right now, because we know that you need to get vaccinated and how important it is. So I wouldn't worry about that. So I also want to just comment on the administrative staff who are not prioritized right now. However, if you are over the age of 55, then the AstraZeneca is available. So you could come and get vaccinated in that context. Rachel, could you just repeat the question because I'm trying to catch up on the other two. It was about, Rachel?
Quelqu'un avec une maladie chronique, moins de 55 ans, un employé qui veut être vacciné au CUSM.
Okay. Oui, je m'excuse, oui, tout à fait. Alors, les maladies chroniques, nous avons reçu la liste à peu près 10 minutes avant le webinaire. OK? Donc, on a vraiment besoin de digérer exactement de qui il est question ici. Pour le moment, ce qu'on sait de façon générale, c'est que les maladies chroniques, so chronic illnesses, apply to people who have regular visits at the hospital with a specialist. So that is the definition that the ministry has given right now. And then the types of illnesses, we really just received it a few minutes before this webinar. Now, we already had an urgent meeting this morning with a subgroup of the Vaccination Prioritization Committee to try to see how we would approach vaccinating our patients. I'm also seeing questions, and I'll jump ahead a little bit here, Rachel, because I'm seeing questions about the clinics. Now, there are a few key principles here. The first thing is that our vaccine allotments are 2 weeks, we are given them 2 weeks ahead of time. So we're kind of locked in to the doses, the number of doses for the next 2 weeks. So for the week of April the 12th and the 19th, we're locked in with a certain number of vaccines that are coming to the MUHC with appointments already given. So the marge de manœuvre, or the maneuverability for the next 2 weeks for our clinic patients is not going to be huge. So one of the things we discussed this morning, une des choses qu'on a discuté ce matin, c'est qu'il faudra avoir un message très clair pour les patients et nos cliniciens que la semaine prochaine, lundi matin, on ne pourra pas vacciner tous les patients qui se présentent à des rendez-vous. Et pour avoir regardé rapidement la liste que le ministère vient de nous envoyer, c'est pas mal tous nos patients au CUSM qui tombent dans la catégorie. Il y a peut-être des exceptions, mais je ne les ai pas encore vus, puis je vais regarder tantôt avec une loupe, mais je ne les vois pas. Donc, ça ne sera pas possible lundi matin de vacciner tout le monde, puis on est en lien avec les communications pour s'assurer que notre site web est clair là-dessus et qu'il y a un message qui est envoyé à la communauté pour expliquer la chose. Donc, ça, c'est la première chose. La deuxième chose qu'on a décidé ce matin, c'est qu'il y a plusieurs personnes qui sont en train de nous chiffrer le nombre de patients que ça pourrait représenter au CUSM. So we're looking at the number of ambulatory visits per week at the MUHC for patients who would be under the age of 60, or who have not yet received vaccinations. We're trying to get that data extracted. On essaie d'avoir ces données-là le plus rapidement possible pour pouvoir donner à Patricia l'information pour qu'elle aille demander au ministère si nous allons vacciner tous ces patients-là, nous avons besoin de X doses de plus parce que nous avons nos travailleurs à vacciner pour la deuxième dose et nous avons une vaccination populationnelle en cours. Donc, il faut qu'on sache combien de vaccins de plus on a. On ne les aura pas lundi matin. Alors ça, il faut que ce soit très clair et la communication va être faite dans ce sens-là tantôt. Bon, une fois qu'on a dit ça, nous allons regarder la liste des maladies chroniques. Comme je vous dis, j'ai l'impression que c'est pas mal tout le monde qui est impliqué. Et là, il faudra se donner une façon de fonctionner. Aujourd'hui, à 12h43, je ne peux pas vous le dire encore, on est en discussion, le comité se revoit demain. On va avoir une meilleure idée sur le nombre de doses qu'il faudra donner et on va discuter des modalités. Donc, c'est un déploiement qui va se faire. The deployment is going to happen over the next few weeks, but it will not be on Monday morning. There's a lot of work to be done. I just want to remind you, we were informed about this yesterday, and we received the list literally 10 minutes before the webinar. So we're as anxious as everybody to get our patients vaccinated, but there are many moving parts here. So I'm not sure if I'm answering the question, but certainly for the person who was asking with a chronic disease, if what I saw in the chat is correct, that particular disease is not included, but there'll be more information to come.
Merci Eva. Alors, je voudrais rappeler à tous les participants, si vous voulez déposer une question, please do it in a Q&A, dans la question et réponse, et pas dans le chat. Nous n'allons pas répondre aux questions qui sont dans le chat. Nous regardons les questions et réponses. Thank you, Dr. Sidorovich. I think it covers a number of those questions. Maybe, Rachel, we can move on to a new one.
Yes. There was a question also, what if patients are asking for a proof of chronic illness because they want to go to another vaccination site? Is that something we're going to encourage, or we're going to basically say, no, you should wait and get your instructions from your treating physician or your clinic?
At the present time, the way that I understand what the minister said yesterday, the patients who fall into the category of chronic disease under the age of 60 to be vaccinated, they are to be done within the hospital setting of the specialists that they are seeing, and not to go to the vaccination centers that are at the Palais des Congrès or elsewhere. So it really is hospital-centric right now. So I don't think that there should be any requests for documents because the patient is followed with us and not with somebody else.
Thank you.
Rachel?
Now a question about masks. Is wearing a surgical mask now mandatory at all sites, even in offices when sitting at a desk?
Caroline.
Oui, je vais m'en occuper. There's a lot of questions regarding that particular issue. We've all read in the newspapers during the week that now we have to wear masks, even though we work in an isolated office with the door closed. We are still waiting for the answer from the ministry. So we will discuss this matter this afternoon at the CCMU, and we will issue a statement tomorrow or by the beginning of next week.
Thank you, Caroline. So for today, status quo, and we maintain the policy that has already been adopted.
Yes, exactly.
Merci, Caroline. Rachel.
Question par rapport
Rachel, sorry. Dr. Sidorovich wanted to add something on this topic.
Not to that topic, but just to what I had said before, because I'm seeing questions in the about the pediatric group. And yes, we are including patients that are 16 and over. So in the meeting this morning, we had pediatric representation. So those patients will be looked at also.
Très bien, Eva. On va laisser Rachel gérer les questions parce que sinon on va avoir du mal. On est trois à essayer de mener la séance. C'est un petit peu difficile. Rachel.
A question about whether the variant is more dangerous for children or more children being hospitalized than in previous waves. Is there any idea or news on vaccinations for under 16?
Dr. Lefebvre?
Yeah, so the variant is, so far, we're not seeing a signal that it's more dangerous in children. We have not seen a rise in our pediatric hospitalizations in recent weeks. It's definitely more the variants are definitely more transmissible across all age groups. But we are not at this point seeing any signal that it is causing more severe disease in children.
People are reacting to the patient that apparently deceased at Saint-Justine, right? They are worried about this case. Would you like to say something about this?
Yeah, I don't have the details on this case particularly. What we know from pediatric hospitalizations, and the data that's been published is that children with COVID-19 who tend to get hospitalized because of COVID-19 are those that usually have underlying chronic conditions, usually more than one chronic condition. So those would be the same children who would be vulnerable to get severe flu and get hospitalized due to flu, for example. So hospitalizations in children remain exceedingly rare due to COVID-19. And so I don't know the details of that patient at Saint-Justine. I can't comment on that.
Merci, Dr. Lefebvre. Rachel?
Do we know how effective the vaccines are on variants?
Yeah, so it appears that most vaccines that are being administered are efficacious against the UK variant. There may be some diminished efficacy against the South African variant, and I'm not sure we have much data for the Brazilian variant yet. But we know that vaccine manufacturers are tweaking their recipes to be able to target those variants that have mutations like the South African one. And we'll see next year or during the fall season, maybe we'll have different vaccines that are targeting these variants.
Thank you, Dr. Lefebvre. Rachel?
What was the variant situation in Israel, and what vaccine did they receive, if you know?
So I don't have the exact data on their variant rates. I mean, I know that the UK variant has been circulating there since December, just like it had in multiple countries in that region. They have also had cases of the South African variant, but I can't comment exactly on the percentage of their circulating cases that are variants. In terms of which vaccine they received, from what I understand, it's been overwhelmingly Pfizer, because there was an arrangement with Pfizer to provide doses to Israel so that they could also provide the data in real world. So I'm not sure if they vaccinated with other vaccine, but I think predominantly Pfizer.
Thank you. Rachel?
Si les employés d'administration sont en contact avec du personnel infirmier qui est en contact avec des patients, sommes-nous éligibles à la vaccination actuellement?
Dr. Sidorovich?
Oui, j'ai pas compris le tout premier mot, là, je m'excuse de la France. Des gens qui viennent d'où? De
Personnel administratif.
Administration, mais sont en contact direct avec les infirmiers.
Oui, tout à fait. Ben, en fait, nous avons regardé justement le personnel administratif qui est à l'hôpital, pas ceux qui travaillent soit de la maison ou qui sont sur un site non clinique. Et ces gens-là qui sont vraiment à l'hôpital et qui sont en contact avec patients ou collègues cliniciens pourraient être vaccinés. Et en fait, cette liste-là était en train de se faire dresser là, la semaine dernière et cette semaine. Donc, peut-être que cette personne-là pourrait m'envoyer un courriel là, juste pour s'assurer qu'elle est dans la catégorie qu'on était en train de regarder pour la vaccination. En fait, il y a plusieurs personnes comme ça qui vont être vaccinées la semaine prochaine. Donc, peut-être juste me confirmer ou m'envoyer votre nom là, pour que je sache si ça tombe bien dans le bon groupe.
Donc, cette liste-là, les gestionnaires sont au courant et vont donner des rendez-vous à leur personnel. C'est le processus habituel.
Ben, oui, ben, là, on est vraiment en train, c'est suite à la directive numéro 2 du ministère où se rajoutait ce groupe-là. Donc, au comité de vaccination, nous avons revu des groupes qu'on avait refusés dans le passé pour voir si maintenant ils passaient la barre, de 1, et de 2 aussi d'autres personnels qu'on n'avait pas considérés avant, mais qui maintenant, parce qu'ils viennent à l'hôpital un jour ou 2 jours, là, ils sont en contact avec les cliniciens, si maintenant ils sont accessibles à la vaccination. Et c'est ça qu'on est en train de regarder. Donc, peut-être que cette personne-là pourrait m'envoyer un courriel. Ça me fera plaisir de lui répondre.
C'est sûr que le courriel s'en vient.
Ah, j'ai aucun doute là-dessus.
Merci, Eva. Rachel?
Is there a provision for vaccinating psychiatric outpatients?
Eva, sur les patients psychiatriques?
Oui, alors ça fait partie, so I think the question was in English. So in terms of the mental health mission, I need to look at the list from the ministry again that we received 10 minutes before, but certainly in this morning's conversation, it was definitely part of the picture, but I just need to have a look at that list again, and we will definitely get back to you via Antoinette DeRay and Maryse Godin. So yeah, we'll let you know.
So there'll be communication around all of this new reality. Is that the patients that are our patients or regular visitors versus the list that was issued this morning, and how we're going to structure the vaccination for those people. There'll be a communication around this. And we know people are anxious. I would be anxious also. I would be calling, but the reality is that the announcement at the ministry is done at the same time to the general population and to the institutions. So the mechanics that need to be put in place is being done as we speak. Rachel?
Considering there are so many spots not filled for the vaccination clinic, why can we not give those slots to family members of staff?
Patricia?
We do have to follow the directives of the ministry. So everyone that we vaccinate is being entered in the registry, and they're being looked at every day after closing time. And I can tell you that the inventory and the vaccinated number of people is being looked at on a daily basis. So we have to follow the MSS's directives.
I understand, Patricia, that we have a list of people that we can call at the end of the day if we have extra vaccines that were not allocated. These are specific ones, right?
Yes, in the last hour, if we find that we will have extra doses, then we do call healthcare workers on site. We have our security agents that we call. So we have a list of people, but they need to be able to come in within 30 minutes. So we go with that list on site. We haven't lost one dose to this date. The only time we lost one was a problem with a vial, but it wasn't because we didn't vaccinate. The service by pharmacy and the coordination is excellent. We dilute on an hourly basis our vials, and it's calculated every hour based on our people in the clinic and on appointments. So when we do have end of days, it's always less than 6 doses per site. And there's some days it's even 0 doses left.
At the regional basis on Monday, it's true that there were appointments that did not find someone. So the ministry is asked to close those appointments in Montreal, and the vaccines were reallocated to other regions that were experiencing higher number of cases. So there's actually a good match between the appointments and the available vaccine. Rachel?
Yes. Il faut prendre en compte qu'il y a environ 50% des visites qui sont en téléconsultation et que ces gens voudront venir en personne. Cela aura un impact sur tout le monde. Secrétaires, infirmières, les lignes téléphoniques explosent déjà depuis hier.
Alors, c'est pour ça que Dr. Sidorovitch a déjà commencé à travailler avec l'équipe de priorisation, Chantal Souligny, avec les cadres supérieurs des secteurs cliniques. Il faudra que nous communiquions rapidement avec les patients. Il y a des patients qui ne viennent plus en personne, ils sont suivis à distance. Donc, cette mécanique-là va devoir changer si on doit les vacciner. Et on doit bien préciser quelle est la mécanique par laquelle ce rendez-vous-là sera organisé. Il faut aussi comprendre qu'il doit y avoir des vaccins dans la clinique au moment où le patient vient. C'est ça qui est toute la complexité de l'exercice. Alors, ce sont des enjeux importants qui sont soulevés, qui sont bien compris, pour lesquels on va avoir des réponses dans les prochains jours. Alors, on vous demande de tenir bon, là, ceux d'entre vous qui travaillez dans les cliniques. On va essayer de vous donner rapidement les lignes de com et les instructions pour les patients qui doivent vous appeler en grand nombre. Bon courage. Rachel?
Can you please clarify the N95 recommendation for physicians seeing pink patients in the ED who are COVID unknown?
Pink patient in the ED, Dr. Lefebvre?
Yeah, I think this is referring to COVID suspect or confirmed patients in the emergency room. So I think your question is relating to the CNESST directive on the wearing of the N95. I don't know if Caroline wants to comment on that, or I can go ahead.
Maybe I can jump in at this point. So the CNESST has published a ruling saying that N95 were to be available for healthcare workers working in warm zones. So that's the last information that you got to our communication. There are still conversations at the ministry level and with the infection control experts in Quebec City and with our experts locally and regionally. So the conversation is not finished. What is clear is that for the time being, if you are working in a warm zone and you want to have an N95 mask, it's available. So that's what we can say at this point. More to come, I expect. A difficult file. Rachel.
Would it be possible to have a general message on the MUHC phone line stating that we cannot vaccinate in clinics as of Monday, or something to this effect?
It's probably being worked on this afternoon. I see that Eva is nodding, so yes.
Okay. It would seem that the second dose seems to provoke more significant symptoms. In some cases, that might mean that the individual will not be able to return to work that day or the day afterwards. This is of concern in the emergency department. So is there any information on that issue?
Dr. Lefebvre, est-ce que vous avez de l'information sur la réaction après la deuxième dose?
Yes, it's true that there's a higher incidence of systemic symptoms like fever, chills, muscle aches after the second dose. However, so in terms of not being able to work because you are really affected by the symptoms, that's one issue. Not being able to work because the symptoms could resemble COVID, that's a separate issue. So we have a strategy to manage those symptoms, those healthcare workers when they present with symptoms. Within 48 hours of the vaccine, if the symptom can be attributed to the vaccine, we are comfortable with testing you, but allowing you to remain at work, provided that you don't display a symptom that's classic of COVID, like loss of sense of smell, loss of sense of taste, a cough, because that cannot be induced by the vaccine. But if you have a mild fever, some muscle aches, some joint pain, some fatigue, within the 2 days of getting your vaccine, that is completely expected. And what we would recommend in that case is that you get tested, but you can keep working if you feel up to working.
Thank you, Dr. Lefebvre. Rachel, one last question.
For patients with variants of concern, are they still considered recovered at 10 days, or should it be longer given that these variants are more transmissible?
So the duration of contagiousness remains 10 days for patients who have a normal immune system and who have not been in the ICU due to COVID. There is differing recommendations in different countries. Some countries have extended to 14 days. In Quebec, we have not done that yet. I don't think there's yet strong evidence to say that the duration is significantly longer than with the original strain. So far, until we have any more news, it's still 10 days.
Merci, Dr. Lefebvre. Merci à tous les participants. Merci aux panélistes d'avoir resté là. Merci particulièrement à Dr. Lefebvre, Dr. Meyer. Thank you very much for your two presentation. And we'll see you soon. Thank you. Have a good afternoon.